How this works is each presenter is going to have about 8 minutes, and I'm going to make these introductions really short, just so that there is time. So first up, we have Damian Gilbert. He's the CEO of TouchCare, who is also one of our sponsors. He's a Duke alum too, and we are very proud to also have you here. So, all right, Damian.
So my name's Damian. I'm basically a washed-up investment banker. I graduated 20 years ago from Duke and moved around the Wall Street from it. And the last time I was having a wonderful
Can't hear you.
Yeah, can you hear me now? What about if I just speak more loudly? That's all right, I can just speak now. All right. So I graduated Duke in '96, spent 20 years in Wall Street, moving around, like I said. And I was at a lovely private firm. We used to fund a lot of social media digital companies. And one day I sort of had this idea, which was, how do I build something that's actually going to be meaningful in a year's time instead of basically chasing my tail the whole time. After funding people for too long, I decided to quit my job, pack up the minivan, move back to Duke, and build a couple of startups. So I have a group in town and backed by a private equity firm. We're building healthcare innovation startups. And I'm English. I don't know anything about ice hockey. This is my favorite sporting sport in the world. And it's kind of what we're talking about today, how do we do what's going to be here tomorrow. So let me tell you about TouchCare. It's a pretty big idea. I've got 4 kids, and we used to spend far too much time driving back and forth across Westchester County to go see our pediatrician. And I would beg my doctor, can we do a video call with you instead of having to drive? And he would say, no. I'd be like, can we do a Skype call? No. Can we do FaceTime? No. So let me ask you a question. Raise your hand if you've done a video appointment with your own physician in the last month. 6 months. 1 year. Wow, this is a good opportunity, right? You can't do it. You just can't do it in the world. Raise your hands if you've done a video call with a random doctor in the last year. American Well, Doctor on Demand, whatever, right? So one of the companies, so in my old place, we were involved in some pretty cool social media companies. And so I sat down with a group of friends and said, we're going to build an app that makes it really easy for you to do a video call with your own doctor. But we're going to do it in a smart way. We're going to think like consumers. So we sat down and sort of said, what are our favorite apps in the world? And these at the bottom. LinkedIn, for when my startup fails and I need a job. Dropbox, because I always lose my photographs. Instagram, because I've got teenage kids and you've got to follow them and see what they're doing. Facebook, because it's Facebook. And Uber, because it's just awesome. And there's TouchCare, look, our little logo. And what we loved about these apps, seriously, was that they're free, they're simple, and you invite your friends. So that's TouchCare. TouchCare is free, it's simple, and you invite your friends. Here's how you get on TouchCare as a doctor. It's really hard, it takes you about 2 minutes. You download the app, you set up a profile, you invite your friends to connect. So they're not your friends, they're your patients. It works with Epic, it works with Allscripts, it works with Athena, it works with everything. You don't change any workflow, you don't have to pay anything. It takes you 2 minutes. It's like LinkedIn, it's like Evernote, it's like Uber. So, that's TouchCare. It's live today. It's in the Android store, Google store. It's in the App Store. And so, what we did is we kind of sat down with a few friends. I went and pitched some friends of mine in New York. We raised $9 million. They told me I was crazy to come to Durham because it'd be harder than going to the Valley, but we've done it anyway. We've got 20 people down the road. And we've got places like UNC Chapel Hill using TouchCare. ED doctors at bedside say to a patient, do you have an iPhone? They say yes. They download the app. They invite them to connect. They do a follow-up 2 days later to prevent a readmission. We've got primary care docs using it. We've got brain surgeons using it. Mount Sinai in New York's using it. We've got sports teams using it so their team docs can stay in touch with patients. And this is really important. To the left is what I call telemedicine 1.0. It's like looking at an IBM mainframe. It's big, it's enterprise, it's clunky, it costs lots of money, it takes time to develop and time to deploy. And on the right is a bunch of sort of cloud-based, consumer-minded folks that we like to be one of, which are scalable, massively deployable, no integration, no development. And this is what it's all about. I purposely skipped the other slides, it's boring and banker-like. It's the rise of the healthcare consumer. Kind of cool to be in this room today and listen to a lot of stuff, but you've got to think like a consumer. This is my thing about consumer engagement, right? Patient portals don't work, I think that's proven. So I think it's going to be a really interesting thing over the next 2 years to see how patients engage with their providers. A couple more quick points. You can do everything on your phone today except healthcare, right? That's kind of the opportunity for TouchCare. Another quick point, because I know I've only got a few minutes of time. If you're a provider today, this is kind of like my pitch to a provider. You're at the bottom of this competitive chart. You've got now urgent care people trying to come take your business every day of the week because it's easy. In the middle, you've now got the big guys, Walgreens, Target, Walmart, all moving into the primary care business. And then you've got all these online guys, not guys like me, these are guys who provide you a random doctor license in your state right now for $40. For fun, by the way, go on Doctors on Demand tonight, do an instant call, it's $40, you get a prescription in about 3 minutes. One of the reasons Blue Cross invested in us was they like the fact that we are enhancing continuity of care between a provider and their own patient. They know the patient, they have the EHR, it's like a continuous care. This is commoditization of healthcare, which is probably not a good trend. TouchCare in the real world, we've got a bunch of users. We started 12 months ago, we raised money, we spent the first 6 months building a really basic widget held together by duct tape, put it out in the market, let doctors play with it, took the feedback, redesigned it, launched it in January. We've gone from like 0 to 3,000 providers in like 5 minutes. It's a little scary actually. And so, this is my message to Duke because I'm a Dookie. I went to see some of the Duke physicians. I don't know if any of you guys are in the room, some senior old guys with lots of experience, and I don't really know anything about healthcare. And I said, how about I give TouchCare to Duke free and you guys can just use it? And they're like, well, I've been doing healthcare for 20 years. If my patients need me, they can call me. I'm like, oh, great. So I went down the street to Chapel Hill. Luckily, my wife went to Chapel Hill. And they said, that's awesome. We'd love to try it. So my plea to you guys as a Duke graduate, and if one day TouchCare goes public, there might be an endowed share, you never know, is give TouchCare a try. Seriously, if you're a provider in the audience, download it right now, invite a patient, do a video call today, and you're done. You're live. We've got serious financial backing. Blue Cross Blue Shield of North Carolina is on our board. They put $5 million in the company recently. We're going to roll it out to 17,000 providers in the state. We're rolling out in Florida, we're rolling out in Philadelphia, a bunch of other places. We've got a $65 billion private equity firm on our board of directors, and a former United States Senator, Bob Kerry, who's on the board of Tenet Healthcare. So we're just starting to gather speed, and pretty happy to be here. And if anyone who is in data or coding would like a job, I'm at 208 Rigsby Avenue. Thanks a lot.
Great. Thank you so much. We do have time for a question or two. Does anybody have a question?
Yes, sir. So, I'm not going to reveal salary details. I'm trying to remember that.
I have kids, and I asked the same question. Our pediatrician said no. I think the primary concern they had is that if they provide answers to us and that turn out to be wrong, there might be legal responsibilities. How do you handle that? That seems to be...
So I'll answer that very simply. If they provide you an answer that happens to be wrong, it could be liable for that. Whether that happens in person or they're looking at you on the screen, it's your doctor, you're looking at them face to face, they've got professional judgment. If they say, you know, Victor, I need to touch your shoulder, I can't advise you on it remotely, they'll tell you to come in. If they don't, they won't. It's you, it's your patients, it's your discretion. Now, here's the other thing that's really funny. Docs have been doing telemedicine for years, on the phone, not HIPAA compliant, not covered by insurance. Bad. TouchCare, HIPAA compliant, is reimbursed under some plans, and is also authorized by the medical board, as long as there's the prior existing relationship, etc., etc. So the way TouchCare really works, obviously, I'll come to this in a second, is you call your doctor, I'd like an appointment. They say, Victor, you want to come in, or you want to do it on TouchCare? And you're like, I'll do it on TouchCare, please. And they're like, great. 2 o'clock, up on TouchCare, we'll see you then. Yes, honey.
Fantastic and exciting. How does the doctor chart that encounter with TouchCare?
So whatever EHR you use, just use it. So Mount Sinai and UNC use Epic. Their doctors sit in front of their computer or laptop or wherever they want to do it. They have a little iPhone or Android right by the side, and they chart in their existing EHR with no change. They just code it as a telemedicine visit. Blue Cross Blue Shield, by the way, has an e-visit policy with a CPT code that reimburses for these visits. But there are some things that, you can, like surgeons using it for post-acute follow-up, do it under a global rate, so there is no reimbursement. ED guys doing it for, direct reimbursement. I mean, the whole idea here is literally that this should be as easy as Instagram. I don't know how many of you use Instagram, but if you don't, it's like you click follow me and you get accepted and you're in network. The next thing we're bringing out, which is pretty cool, is one-to-many messaging. So a doctor can say, it's snowing today, we're closed, click, and if you follow your doctor, you see the push, right? No one, this is my bad, I'll say it publicly, no one's saying it. I'm skeptical that my charts will ever take off as a patient-to-provider communication device, just because I know the way the world works. It's why we're all on WhatsApp, and Snapchat and Facebook, and we're not using our company communication portals. It's the same sort of principle. It's like UI, UX, ease of use, etc. Any more questions?
All right, great. Right, thank you. Yeah, sure.
One more, because I did pay a couple of $1,000 for sponsorship.
Absolutely.
It's like 15 minutes, Geico says you're 15% car insurance, it's like $5 grand buys you 8 minutes at mHealth, I do.
I was going to say, I work with our pregnancy medical home in the Medicaid population here at Community Health.
Yeah.
Many rural counties in North Carolina, women have the closest hospital to deliver a high-risk baby is here at Duke. And I visit those health departments, and a lot of what I'm seeing is women are having their babies in cars because an hour is a really long time. I'm not saying for delivery, but if also docs will check in with these high-risk moms via their tablets. But the one thing I would say is a lot of this Medicaid population, they don't have smartphones. So we would have to find a way to get them a device or tablet so doctors can connect them. But I can see this being really impactful in our rural areas of North Carolina.
Yeah, I do too. So 2 things. One, you guys don't ever need to TouchCare. Talk to TouchCare, just download it, use it. That's the first thing. So just use it. And if you want to upgrade to a clinical version, that's when you'll start paying me, but it's still like a Dropbox subscription. Second thing on maternity, I also have another company called Baby & Company, which is doing outpatient maternity centers. We have one open in Cary in partnership with Wake Med. But to that point, look, not everyone has a smartphone, but none of us today are wearing an Apple Watch. I've just ordered 3 actually, because we want to use them and sort of get to play with them. But the point is, today that is the case. But you know what, the millennials, in 10 years' time, in a decade's time, this will be so old-fashioned and boring. People are like, I can't believe that you once had that stupid idea of doing a video type of call. I mean, it's going to happen. It's just a question of proliferation. In that instance, I love actually the idea of how do you get devices to these people, and someone else talked about cheap Android devices. You can get this stuff out there pretty cheaply, but the best distribution model on earth for this stuff right now is a smartphone. There's nothing better. Thanks, everyone.
All right, thank you so much, and also thank you for your sponsorship too. So, all right, and next up we have Dr. Pat Calhoun, who's a professor at Duke, and his talk is entitled "The Mobile Contingency Management to Reduce Smoking." Sorry.
Great, thanks. So Bernard mentioned this morning that Durham is the Bull City. What he failed to mention is that it's named after a tobacco company, Bull Durham Tobacco. And I love these ads from the 50s. It shows that hindsight is 2020. It wasn't that long ago that the medical community was used to reassure an anxious public about the safety of tobacco. Smoking continues to be the #1 cause of preventable death in the U.S. It accounts for about 443,000 deaths per year. And the current smoking rate is about 19%. If you look at this graph, it has seen a steady decline since the 50s. The last 10, 15 years or so, the smoking rate's pretty much leveled off, which suggests we need to do more to reduce the smoking rate. Veterans smoke more than the general population. Where I work at the VA, I actually got interested in this work as a clinical psychologist working in a specialty PTSD clinic, because 60% of the people that I was seeing were current smokers. And so the folks, especially among Vietnam-era veterans, we were seeing they were being diagnosed with conditions that were ending their life. They're all smoking related. So we did a lot of work that I won't really talk about, that looked at this PTSD smoking comorbidity. We actually used electronic devices, electronic diaries. Back then we started with Palm Pilots and now are using smartphones to do ecological momentary assessment. And all that work really was to inform new treatments. Unfortunately, we've done a number of trials with PTSD smokers that turned out to be negative studies. What all these studies suggested to us is that we really needed more intensive interventions for this population. So before I quit, we asked ourselves what would BF Skinner do, and we turned to this idea of contingency management. So CM is based on operant conditioning principles. There's a lot of evidence that shows that it's very efficacious, at least in the short term, to decrease all kinds of drug use, including tobacco use, in a number of hard-to-treat populations. The problem with CM is that it is complicated, and the implementation of CM has been extremely limited by the need to verify abstinence 2 to 4 or more times daily. So really it's been relegated to day treatment programs. And if you start thinking about the way smoking cessation care is delivered, very few people are getting intensive treatments, not just CM, but other intensive behavioral therapies. And so what we wanted to start thinking about, if we want to make an impact at the population level, we need to start thinking not only about the best and most intense treatments, and that's really what psychologists tend to think about, we want 12 sessions of psychotherapy, we want it really, really efficacious, but we don't spend a lot of time thinking about how are we going to get people to get the treatment. So we wanted to increase the reach of intensive behavioral treatment for smoking, and we thought that mHealth would be a great platform for that. We were aware of the work that Jesse Dallery was doing down in Florida with internet-based CM approaches, and we thought we ought to do this with smartphones. So we developed an app. This is what it looks like. It's very simple. There's essentially four buttons for patients to push. They record a video themselves, plugging into a CO monitor. This is what that looks like. That's Jeff Hertzberg, who's our developer. That video gets encrypted and uploaded to a secure server. They also have the splash page where they can look at compensation, how much they've earned. We can send them notes. And this is the web interface that we see. And we enter their CO reading in the background. The site, figures out what the information that they get back on their app tells them how much they've earned for that reading. We've done 2 pilots now, one in PTSD smokers and one in homeless veterans. Across both those studies, adherence with video uploading was really, really good, which we were happy about, but I was more happy with the outcomes that we were seeing. We're frankly blown away by the quit rates in these 2 trials. So 3 months quit rates of 50% among folks with PTSD, 6-month quit rates of 45% in a small sample of homeless smokers. So this told us that this mobile CM approach is feasible in hard-to-treat populations, and we think that in combination with other evidence-based CBT, cognitive behavioral therapy for smoking to target relapse prevention, that this approach really has merit. And we now have 3 projects funded by VA and NCI. One is in rural veterans. We've enrolled 203 folks so far in that trial. Half those have been randomized to the mobile CM. We actually provide folks cell phones. Thanks. We provide folks cell phones in this trial. The VA has very strict information security protocols, and not many cell phones meet that. So it's FIPS 140-2 for you information security geeks out there. And so we actually provide phones to them. We've lost, in 200 patients, we've lost 5 phones so far, which is actually less than we thought we would. So that's great. And I'd just like to thank our lab, a number of really great folks that I get to collaborate with. So thanks.
There is time for a question. Okay, all right. Thank you very much, Dr. Calhoun. So up next, I would like to present the winners of our Shark Tank challenge. Let me just find your presentation. Is the PDF? Okay, right here. All right. Yeah. Sure. Minor delay. Okay, great. All right. All right, thanks, Erica. All right, I'd like to introduce to you, and I'm probably not going to say your names correctly, so I do apologize. Parth Chodavadia and Suhani Jalota. All right, okay. And they are going to present on a post-sexual assault app for use by medical providers in India.
So on December 16, 2012, Jyoti Singh Pandey was raped in a moving bus by 6 men in the heart of Delhi city. This movement, this case alone caused a movement across the country of India where people started to protest on the streets by saying, enough is enough. And yet, while the entire country watched, Jyoti Singh Pandey died. India is not yet prepared to deal with rape victims. 91 other women, along with Jyoti, were raped the same day, and yet they didn't get the treatment that at least she had the opportunity to get. In fact, when a girl visits a hospital in India now, doctors have no idea, have no protocols in place as what to do. They don't have any standardized protocols because they're taught in the medical education system that when a girl approaches them, they look at them with an eye of suspicion and that they treat them as a piece of a chain of evidence that police must handle and that they themselves must ignore. And so, in the case of an 8-year-old girl, for instance, she was brought to a hospital by her parents, and there she was told by the doctors that in fact she had no issue and that she just needed to take some painkillers and go back home. The parents refused. The parents then they decided to go to another doctor in another hospital, and there they realized that in fact she had a lot of internal bleeding and she needed to be examined further. This shows that the Indian medical system does not have any standardized protocols in place as to give doctors any sort of instructions. In fact, within the same hospital, you could have 10 different protocols depending on which doctor the victim actually tends to. And so there's a need for a tool in place that assists doctors try to examine the different medical issues and the trauma care that comes along with treating mental trauma care that comes along with treating these rape victims who come to hospitals, treat them as patients and not just as victims. And also understand the physical injuries, not ignore them, treat them for that, and also treat them for the sexually transmitted diseases that could be caused due to the rape incident.
So this is where mBadlaav comes in. mBadlaav aims to provide a step-by-step live guide for healthcare practitioners and also broaden the focus when a rape patient arrives to a hospital from an evidence-based approach to a more patient-centered approach. On the surface, mBadlaav is a healthcare decision support tool and a data registry tool that not only allows doctors to better understand what to even do when a rape patient arrives, how to even collect information about a rape, but to also digitize the process of collecting information about a rape, improving efficiency, and with the press of a button, they can send all of this information in an electronic report to the police. In this regard, mBadlaav sort of serves to facilitate communication between a rape patient and a doctor, and not only empower doctors to confidently provide care for rape patients and better understand exactly the protocols that are necessary to take when trying to treat a rape patient from both a physical and mental standpoint, but also empowers women to confidently seek care in hospitals where such standardized protocols are in place. So let's take a deeper look as to exactly what a protocol or checklist would look like in terms of when a rape patient arrives at a hospital and how the doctor would treat them. So let's say a woman arrives at the hospital claiming to be raped. A doctor or nurse would first see to her, and then the mBadlaav application would open up and provide a protocol and a checklist as to what to exactly do when these rape patients arrive. So first, the doctor would receive consent from the patient as to whether they even want to be treated for the physical or mental trauma that is caused by rape, and then go on to provide immediate first aid, as well as collect a history of the patient to understand better how to treat the rape survivor that has come into the hospital. Following collection of history, the doctor would then examine the patient, estimate the age based on dental features, and also collect evidence with regards to legal issues that are surrounding rape, and just to make sure to identify possible approaches to take when identifying who committed this rape and how this rape occurred and where it occurred and when it occurred. The doctor would then provide treatment, as Suhani mentioned, for injuries, sexually transmitted infections, provide emergency contraception if it's necessary, as well as any surgery or medication that is necessary, according to what the doctor thinks is best fit for the patient that has arrived at the hospital. And then the most important component is to provide these rape survivors with the means to better undergo through the process of mental trauma, better understand their mental trauma, and sort of get followed up or referred to a psychological counselor or a psychological counselor that might be already present within the hospital. So once we establish this logic tree of questions, we hope to expand our application to incorporate 4 other components: geomapping of rape locations, real-time data analytics, rape kit ordering service, as well as a mental health referral system. By incorporating all of these 5 components into a single mobile application that can be downloaded anywhere within India, at any hospital, by any doctor, we hope to not only standardize protocols for rape when a rape survivor arrives at a hospital so that they can confidently seek care, but also to serve as a source of crowdsourcing of data for the government to better understand where hotspots for rape are, when rapes are more likely to occur, as well as mobilize police surveillance systems in accordance with where rapes are most likely occurring within a particular city.
Right. We hope to also have a revenue stream over here. So we have 3 different ways in which we hope to get that. First is a hospital subscription fee, where hospitals would then subscribe their doctors into this, getting to this application. Then we also have rape kits, which essentially try to accumulate different things, such as even a simple nail cutter, which is not existent in a lot of areas in a hospital, that's needed to provide some sort of evidence to police cases. So rape kits would be sold to hospitals. Then we would have advertisements in the mobile applications that would again be catered towards the doctors themselves in the hospitals, and so a lot of pharmaceutical companies, for instance, would like to advertise on that application. And we hope that through this kind of an application, we have an increase in the reporting of cases as well, so that girls are more confident in seeking care at hospitals and in reporting the cases and in reporting where it occurred and the details of that, as well as the doctors are able to adhere to protocols, because now they would have a tool in place that they need to adhere to. And then the psychological trauma, the mental trauma that exists after rape would then be reduced as well. So we hope that this will become a much safer curative system for the rape victims as well. And I guess this is, thank you. Yeah.
Time for a question.
Sure.
Are you sending this information back to the government? This is what I'm getting
To the police.
Is it the central government
Uh,
or the government of each state?
Well, this would be sent to the police officers, essentially. So this is like the local police stations that are involved in the local hospitals that we'll be working with. So we're starting with only 2 hospitals in the city of Mumbai itself. And so the hospitals, so the police stations that are nearby, that's where we will pilot it first. And then when we scale this up and expand this, we definitely look at the municipal corporation of the city of Mumbai and then the states. But central government almost has no power within the states itself. So we definitely look at doing local first because they have usually more regional power.
Which you're segueing into my second question.
Right.
Can the data that you are collecting and the treatment and everything else that you're providing, can that be used politically to change policy within India, which is one of the biggest issues?
Right. We hope that. We really hope to move towards that. That's actually where this idea came about, because we realized that there needs to be massive amounts of change in this region, and we're kind of surprised that rape has always been looked at from a legal standpoint and never from a medical standpoint and never from the perspective of the victim, and not just in terms of female rights, but in terms of what she needs to have in a hospital, what she needs treatment for. So we hope that this creates policy changes in the future, but when we start, we want to start with a few local hospitals and then hope that by getting involved with the data analytics that we would provide, that this could eventually lead to ripple effects.
Last question. Can the information that you are collecting on case by case be used as legal evidence against the perpetrator of the crime?
Right. So in the application currently, we would like to maintain anonymity of the girl so that she is more confident in approaching the doctors. But we would also have to have a sample ID. So we want to have a unique ID for each girl so that we can identify, so police and the doctors can identify the cases together. And so that her DNA, for instance, that has to be then put into essentially the information that whether she's actually had the rape incident occur to her or not, and the extent and everything would have to be recorded in the application itself. And that information is then sent to the police just based on her unique ID number and not her name. So it can be used by, for instance, for the legal and the justice system if the girl wishes it to be used for that purpose, when she provides her name and she provides the identity of the people who possibly she remembers. But other than that, we don't hope to make this compulsory for all girls. Because I think that's one of the issues currently, that the police system mandates all the girls to then reveal all information about themselves, and that's not usually, fostering confidence in the girl.
All right, thank you so much. last but not least, we have the winner of a poster abstract submission, Nikhil Patil, who's going to be talking about the passive voltage monitoring and the implications of that for a vaccine cold chain system capacity in northern Nigeria.
Great. I can use this to go back and forth. Okay, great. Good afternoon, and thank you so much for letting me speak on this topic. So yes, today I'm going to be talking about passive voltage monitoring and the implications for vaccine cold chain systems in northern Nigeria. And a lot of those terms that if you are unfamiliar with them, we will review them so everyone is more comfortable with the topic area. So basically, first of all, what is a cold chain system? A cold chain system is a network of facilities and distribution options concerned with the transport and storage of temperature-sensitive medical products from point of manufacture to point of use. I like to think about cold chain systems from the perspective of transporting ice cream, but for our particular project, we focused on vaccines since that's one of the big health areas that we focus on. And specifically, cold chain equipment, which is a term that I'll use frequently throughout the presentation, commonly refers to refrigerators and freezers, which typically require a power source. There are some cold chain equipments now that are manufactured that use like solar direct drives, but we're focused more on ones that kind of use some kind of electricity source, either a power grid or a generator. So vaccines are a medical product, and they are temperature sensitive from both heat and freezing. And the goal of a vaccine cold chain system is to keep vaccines between 2 degrees and 8 degrees Celsius. So this is often a problem in many low-income countries that face energy infrastructure issues, such as unreliable electricity, where there's basically no electricity flowing through a power grid, and then also fluctuating voltage patterns. So often many cold chain equipment, refrigerators and freezers, can experience long periods of no power, which basically then make the vaccines unviable once they are exposed to heat. And then also cold chain equipment can also break down and require a lot of repairs, which is expensive for healthcare systems to have to maintain over time. And this kind of information also has implications for other medical products that require a cold chain, such as blood, HIV test kits, and laboratory reagents. So we started off with the basic question of what is the frequency of power outages over time at vaccine cold chain facilities in northern Nigeria? And we used sensors, low-power sensors, to basically capture this information. And also, because our sensors were able to capture what voltage frequency was over time, that was kind of a secondary question that spurred from the original research question. So why northern Nigeria? I work for a company called eHealth Africa. Our mission is to build stronger health systems through the design and implementation of data-driven solutions that respond to local needs and provide underserved communities with tools to lead healthier lives. We're based in Kano, Nigeria, a very large city in northern Nigeria, but we also have offices in Guinea, Sierra Leone, Liberia, and Berlin. Most of our work focuses in Nigeria on polio eradication and strengthening routine immunization systems, but we also do some work related to emergency management for Ebola, general health system strengthening, electronic data collection, and GIS for public health. But today, I'm focusing on our works looking at specifically routine immunizations. So for our study, basically, for our inclusion criteria, we basically pick health facilities that actually store vaccines using cold chain equipment. There are actually facilities that deliver vaccines to children and other people, but they don't actually have the equipment there. So we want facilities that actually have refrigerators and freezers in the facility. We wanted to look at facilities at different levels of the healthcare system to see if there was kind of a difference between a state-level cold chain store versus a facility at the end of the supply chain. And then we wanted to look specifically at facilities that had both power grid and generator. However, one of our facilities did only have generator because it was a state cold chain and that it needed to have constant power, but it had some interesting results. We picked 3 states in northern Nigeria. We're based in Kano, so we use Kano State. Then we also use Katsina and Bauchi. And for those of you that are unfamiliar with the geography of Nigeria, you can see the yellow shaded states. Those are the states that we picked facilities in. The study period was actually from May to November 2015, from last year. And basically it covered 161 days. And then we used data loggers to record voltage measurements in 5-minute intervals. So this is the technology that we used. We used the Hobo U30 cellular data logger, which basically transmitted the voltage measurements to an online server. And then that inside the device was the FlexSmart True RMS module and the 600 volt AC potential transformer, which actually captured the voltage measurement. And basically we were able to log voltage between 0 to 600 volts and also be able to know when there was power and no power, and also see when there are switches between the natural power grid and generators. So if you have questions about this, we can talk about it afterwards. All the data was uploaded to a server. We used an open source script in R, so this data is open source and available if you are interested in looking at it and doing some analyses. I can give you the link. And then we used the script to process the data and produce descriptive analytics. And the study was funded by Bill and Melinda Gates Foundation and conducted in collaboration with the primary healthcare management boards for Bauchi, Kano, and Katsina State. So here's a map of the 22 different facilities. You can see they're kind of spread out across the 3 different states. So out of the total 161 days across all 22 facilities, sites experienced a total of 10,298 complete blackouts, which means there was no public power and there was no generator functioning. And the median blackout time was 30 minutes. However, I think we used a threshold of no power more than 8 hours because that tends to be the typical cold chain storage capacity of most of these equipments before they basically are not able to keep the product within the temperature range that we needed to stay. And out of the 10,298, 1,196 of those blackouts lasted longer than 8 hours, which is 11.6% of the total outages. So voltage frequency only stayed within the recommended range. Again, we're in Africa, so it's 220 to 240, 10.6% of the time. In addition to the voltage being out of the frequency, voltage was low 26.7% of the time, and this is significant because whenever the voltage is low but not off, basically the compressors are having to work extra, and that can often lead to wear and tear of the machinery, and that could potentially lead to additional breakdown. And then we also saw very large spikes over 600 volts sometimes occurring 3% of the data collection time. So just, we have the data, obviously was aggregated across all 22 facilities, but we also can look at the data individually across each of the facilities. So I just picked 2 different facilities. So here's the data from the Kano State Cold Chain Store, which is the state level facility where the vaccines first come in before they're distributed down to the health facilities. So you can see the voltage monitoring and you can see the distribution of the voltage values. And then this is Katsina Batsari Cold Chain Store, which is actually a health facility where they are actually delivering immunizations to children and other people. And you can see a very different kind of chart for the voltage readings and for the larger distribution of where different voltage rates were captured. So basically, in conclusion, power outages greater than 8 hours are a serious threat to vaccine viability. Basically, vaccines become unviable, you can't use them, can also become dangerous to use, and then has an overall effect on larger cold chain system integrity. And additional frequent power cuts, voltage spikes, and consistent low voltage are potential factors expediting cold chain equipment breakdown. And one of our recommendations is to potentially use this data to advocate for cold chain equipment manufacturers to factor in electricity-related issues when designing cold chain equipment to reduce maintenance and make it easier for healthcare systems to deal with these types of issues. Questions?
If you could just find him during the mixer just after the conference. All right, thanks so much.